right. All right, everyone. Thank you for joining us this evening, and thank you for your patience. This evening's webinar will be given by Dr. Thomas Cha, one of our wonderful spine surgeons here at Rothman Orthopedics. Dr. Cha sees patients at our Bensalem, Newtown, and Doylestown locations, and his presentation tonight is on minimally invasive spine surgery. If you have any questions during the presentation, please feel free to enter them at the bottom of your screen in the Q&A box, and we'll take time at the end to answer as many questions as we can. And you could take it from here, Dr. Cha.
All right, yes, thanks, Natalie, for the introduction. And thanks, everyone, for spending some time. Look forward to sharing some thoughts with you about spinal stenosis and newer surgical treatments. So I'll get right into it. So spinal stenosis was actually first described back in the 1950s. It's a narrowing of the lumbar vertebral canal that's not associated with any other anomaly of the spine. And unfortunately, it's a quite common degenerative condition that affects the majority of the population as you get into the 6th, 7th, and 8th decade of life. Just going to go through a little bit of the anatomy here of the spine so that you can see. This picture on the left shows the spine on a profile view. So the front here is on the left, the back here is on the right. These are each of the vertebrae, these bodies here that looks like a rectangle in the front and then is connected to this arch in the posterior aspect of the spine called the spinous process here in the back. So this is a repeating structure that goes, and you can see everything fills in nicely. And this view on the right side is as if we were looking from behind the body and we're looking right at the back of the spine. And you can see that the spinous process is here in the middle. And what the spine does wonderfully is not only provide motion for the trunk and the torso as it connects the body to the pelvis and the hips, but it also creates a tunnel where the nerves travel through that continue on and to become individual legs, nerves to the lower legs, both to the left and the right side. This view is a little bit more involved, but it is as if you're slicing horizontally through the body. So the front of the body is actually at the top of the screen. The bottom of the screen represents the back of the body. And then this is the left side and this is the right side. So again, to orient you, here in the front here is the spine. This is the disc or the main joint of the spine. And then here are what are called the facet joints. In the back part of the spine, there's both a left and a right facet joint. And then here is that tunnel that I was describing that carries the nerves as they travel down through the midsection of the body and become individual nerves going to the buttocks, the thighs, and the legs. What you could also see here is that the spine is enveloped by a soft tissue envelope, which is called paraspinal muscles, so that these red represent individual muscle fibers. And you can see that these are the muscles that control movement of the spine, as well as protecting the spine and allowing movement in all different directions. This is a picture of a stenotic canal. So like we discussed, spinal stenosis is a narrowing of this canal. And the things that can narrow the canal are, because it's surrounded by joint structures, natural degeneration of a joint surface, which we use the umbrella term of arthritis, that joint surface can then lead to overgrowth of normal components of the joint, as well as the body's response to this degeneration, which can be an overgrowth of bone or a bone spur that we call colloquially. So this, if you remember the picture from before, is the same orientation. This is the front at the top of the screen, the back at the bottom of the screen. And here, instead of that sort of tunnel that would look like a bit of an open circle, this looks like a crimped triangle shape. And it's because this structure here called the ligamentum fibulum is overgrown coming from this joint. And then this structure here in the front is the disc that is bulging and is creating impingement or narrowing of this canal. So this is what spinal stenosis looks like anatomically. Again, this view is that view from behind, but as if we're looking inside the tunnel. But this is just to demonstrate that you could see sort of like an exit going off the highway. At each level of the spine, a nerve comes off, one to the left side, one to the right side. And as it branches off from the main nerve sac, it's traveling right in these areas where those overgrowths and degenerative processes can lead to narrowing of that tunnel and canal. So this is called lateral canal stenosis. And then as the nerve gets out further and becomes its own individual nerve, here on the left side, you can see in the stylized drawing, this is how the nerve should travel, and it travels out this tunnel that is appropriately sized. So the nerve in general should take up about a third of the size of this tunnel. And you can see here on the anatomic section, this is what the nerve looks like. And you can see again that this tunnel is not like a perfectly shaped oval, but again, there's sufficient space surrounding this nerve, allowing the nerve to pass through unfettered. But here, this is an example of a spine that had spinal stenosis, but you can see that the nerve really is not only its abnormal caliber because it's being squeezed, but what it's being squeezed by are these outgrowths here, both, again, coming from the disc or the facet, but these things are narrowing that tunnel the nerve is up. So in terms of spinal stenosis, the clinical presentation typically manifests itself in the middle decades of life, from the 50s to the 80s in terms of patient ages. It has a predilection for females more than males, reasons unknown as to why that would be. The symptoms are typically what's called claudication. So that can present as a feeling of heaviness or feeling like lead or not cooperating of the muscles and areas of the low back and the buttock and the thigh and calf. It could also present as something called radiculopathy, which is a shooting or lancinating type of electrical type sensation associated with pain that could travel through the buttock and into the lower leg area. There are some important other medical processes that you want to differentiate spinal stenosis from. Typically, something called vascular claudication, which has that same term because it can feel the same to some people, but instead of it being from a problem from narrowing and blockage of the nerves, it could actually be from a blockage of the blood vessels that travel to the leg and could give a similar type of feeling. So that is a problem that you want to differentiate. Also, there's something called peripheral neuropathy, which is unfortunately a problem of recovering and the health of the nerves themselves, which can be from various things such as metabolic disorders or vitamin deficiencies, but that can also give you this nerve type pain in the legs. Certain things that you'll find that we ask patients to try to differentiate between some of these other conditions are what makes the symptoms better or worse is things like leaning forward, and as you would if you were sort of able to lean forward and walk with a grocery cart. Could that help you improve your walking distance? Is your walking impaired, either traveling up a hill or down a hill? Because that would change the position of your spine as you're walking. And then, the position that you would be maybe on a stationary bike versus a treadmill. So all those type of things help to differentiate from some of the other conditions that might cause these symptoms, as well as the timing of the symptom presentation. This is what the imaging looks like. Typically, we're obtaining an MRI scan of the spine, and this will allow us to see. So if you look here on this, sorry about that, the MRI scan here on the back, it is that orientation again, where this is the front part of the spine. These are the two joints back here. And you could see, again, remember that triangle from the anatomic specimen, you can see the triangle showing this is a nerve canal that's crowded, and it's crowded from these thickened black substance, which on the MRI shows is the ligaments inflavum. Similarly, here on this bottom view of the MRI, it is that profile view where you could see where that red arrow is pointing is that nerve foramen or that nerve tunnel where that nerve is exiting out. And again, if you could compare what the red arrow is pointing to the other foramen above it, those kind of white ovals with the black structure inside, you can't make out the oval at this L5S1 level. So going forward, the next part of evaluation is a physical examination, and full neurologic examination should be performed to, again, look for other conditions, but also to assess the severity of stenosis, as well as observing through different ranges of motion of the spine. So now as we get to different treatment options, what we talk about first are non-surgical modalities of treatment. So the mainstay is actually injections, and what the injections are called epidural injections or selective nerve root blocks. Think of those two injections areas as either an injection to the central portion of the canal or that exiting nerve tunnel portion of the canal. That's a selective nerve root block. The epidural injection generally will apply a steroid, a corticosteroid, which has a very strong anti-inflammatory effect. And it should calm down the inflammation that is the mediator of the pain and discomfort that the nerves feel. Although an epidural injection might be temporary, it has been shown to delay the need for surgery in many patients and is a very optimal first choice in terms of treatment options for patients with spinal stenosis. It also serves a bit as a surgical prognosticator, meaning that if patients have had symptoms for less than a year, they get about 50% relief of their pain for at least a week after the injection. That can be a good sign of the health of the nerve below the injection, and it would allow really predict potentially a good surgical result. Injections are generally performed through a multidisciplinary team approach. There's doctors called physiatrists, but also pain management specialists that can perform these injections and are an important part of the team taking care of patients with spinal stenosis. Alternative treatments such as acupuncture have not been medically proven to be a form of treatment for spinal stenosis, but is very much a part of adjacent type disorders. In terms of treatment options that are surgical, should those non-surgical methods fail, we recommend surgical treatment. And the goals of surgery are decompression of those neural elements. So the nerve tunnel, both centrally as well as in the exit zone, those are areas where the nerves can be decompressed. And decompression is physically removing those overgrown or bone growth tissue areas while maintaining the stability of the spine, because to get to those areas of the compression, we have to remove normal parts of the spine that serve a function in terms of the stability and motion of the spine. So talking about different approaches to the spine, it's useful to think in terms of the spectrum. You see with traditional open type approaches to the spine, sorry, that's a bit of a gross image, but it does show that to get to the spine, which is unfortunately in the middle of the body, if you have to take a very wide approach to get there, you have to not only make a large skin incision, but just as importantly, perhaps even more importantly, take off some of the muscle as well as the vascular connections and supply of that muscle that you have to cut. As you move through a lesser invasive type approach, there are significant advances through different types of visualization technology, as well as surgical instruments and retractor type technology that allow access to parts of the spine through a much smaller approach and less of that muscle stripping. And then as you get to the sort of the right-hand side of the spectrum, the most minimally invasive techniques, sometimes utilize things such as a camera that allow visualization inside a hole, special port type retractors that, again, instead of even necessarily cutting or violating the muscle tissue and its blood supply, allows you to preserve it. So when we think about the condition of spinal stenosis, and we look at comparisons between what's called an open approach or a minimally invasive approach, at the top here, you could see the open approach. You could see these two retractors that are used to hold the muscles aside. Remember, I showed that first image of the anatomy, the paraspinal muscle envelope. You can see all this muscle has to be taken off from its normal position, which is here, and then held out with these strong retractors during the extent of the procedure to allow safe visualization as well as working channels around the spine. You could see here in this bottom image, if you use special port type retractors that allow still visualization of the areas that need to be removed in terms of the surgery, but allow you to keep this muscle attached, there are benefits to doing the surgery in that fashion. The most important is really decreasing the risk of infection. So that muscle does serve a role and a purpose because it keeps the area of the spine and the muscle envelope healthy and covered. If those areas are removed, retracted for hours, and they lose their blood supply, it potentially becomes a nidus for an infection that could develop after a surgery and potentially require further surgeries to clear the infection and treat. Also, sometimes removing the muscle tissue itself, even though the muscle might heal, the muscle doesn't necessarily work and function in its normal capacity after it heals. So similar to like what a scar is on your skin, it never looks exactly or feels exactly the same. A scar within the muscle, similarly, in terms of electrical stimulation as well as a biopsy and biochemical factors, it doesn't always function, act, and work the same. This showing an MRI study to evaluate the muscles specifically. So if you can see here on this top right image, where my mouse arrow is hovering over, it was in the muscle that was healed after the surgery. You see still streaks of white and scar, which have filled in the areas where the muscle has never completely healed and attached. Whereas on this bottom right image, a surgery done in a minimally invasive fashion, you could see there are less areas of this white streaking within the muscles itself. Generally, it's not a consolidated area of white, it's just streaks of white, meaning the majority of the muscle has still remained attached. So the benefits of this less invasive approach due to the maintenance of the normal muscle tissues and muscle attachments has been shown in published literature to lead to increased movement after the operation, which generally leads to a shorter hospital stay, reduced amounts of blood loss with smaller incisions and the smaller approaches taken to the areas of the spine. And last but not least, but a smaller incision as well in terms of absolute size. So how can this be done? You can see here it requires a significant amount of technological advancements. At the top left here are special type of instruments that can be used and also fitted special type of neuromonitoring leads to evaluate where these instruments are, perhaps without necessarily visualizing them directly with our eye. So we use different types of technology to help not only image where these instruments are, but we could also determine its proximity to different nervous structures as we're instrumenting the spine. The bottom here shows special retractors that allow us to use prior placed instrumentation, the previous portion of the procedure, to then again, not to create another path and a portal through the muscle, but to share and reuse the same minimally invasive portal to get to the spine. But you could see an operating room that looks really like a huge kind of spaceship command center. There's lots of specialized instruments, and there's lots of specialized visualization and technology that allow these surgeries to really perform safely and effectively. And this is just an example of a final image, the one on the left being before surgery and one on the right being after surgery. But this is possible to be performed through two very small incisions compared to traditional open approaches. So I just want to end by saying it's important to realize that this talk definitely demonstrates some of the benefits and perspectives of using a newer type of technology to perform these spine surgeries. But it's still very important, as I started off the beginning of my talk, to appropriately select patients that would benefit the most from surgery. So just because some of these techniques can be performed, it isn't always the best option, but in particular scenarios, especially with disease processes and anatomy that is amenable to this, this can be a really promising new approach to commonly treated spinal disorders. So I want to thank everyone for their attention, and I welcome some questions. So I'm going to stop there, and we'll see if we have any questions in the chat.
Thanks, Dr. Cha. I can read through some of the questions to you if that's good for you.
Okay, yeah, sure.
Okay. So one question is, my first epidural interlaminar injection did nothing, but the second one, bilateral, did provide relief. How long does the relief usually last, and is it only proof that I need surgery? How soon can I get another one, and how many can you get?
Yeah, there's a couple of questions in there, so I'll try to. So the first question about the typical time for effectiveness, and really it can range from days to actually months to even a year of relief. But unfortunately, it's difficult to predict where you're going to lie on that spectrum until you've really done at least one injection. Generally, the first injection or second injection can be a good predictor about what the next or subsequent injection is going to be. Now, I mean, that's not a perfect science there with that answer, but it generally is a good proxy or estimate of how much relief you'll get from another injection. And there is no hard and fast rule about how many injections you would get for a certain period of time. There are some rules that are associated at times with insurance approvals and how many injections might be approved over the course of 6 months or a year. But medically, there is really no hard and fast rule about how many can be achieved. And typically, it's a case-by-case basis where that should be determined.
Okay, and we'll keep the please keep the questions pretty generalized. If you have any really specific questions, that's something that or personal questions, that may be something that you need to be seen in person for. But we will keep them general. Let's see. So what are one question is, what are the dangers of retracting one's nerve doing the surgery in that area?
Yes, I mean, typically when you're the types of things that we retract are the muscles, the skin, certain joint spaces, or what's called capsular tissue. So those are generally the things that we want to retract, and it really is it's more of a time limited threshold in terms of how long it's safe to retract these things and not compromise the tissue that are being retracted. So it's not the retraction sort of just in and of itself, but really the amount of time that is spent retracting. Now, there are times you do need to retract the nerve tissue to perform some of these surgeries, but I would generally tell you that that's typically not done with a retractor that isn't held sort of at all times in the operator's hands, so that the amount of time is as minimal as possible.
Thank you. And then another good question. How does a surgeon know when to perform a laminotomy versus laminectomy to relieve impingement?
Yeah, that's a good question. So going, unlike some of the pictures that I showed, not every spine, as you can imagine, looks like the textbook picture. So again, it's a bit of an individualized picture. Whether or not the stenosis has been around for a long time. Sometimes the left and the right side are very different from each other as well in the patient, or sometimes there's been other treatments or even prior surgeries that have been performed in the area that have to be dealt with. But I would say that it generally does depend on the that particular patient's stenosis visible on their imaging study, such as an MRI, which will determine the right amount of approach for the decompression.
Okay. Someone said they're having an RFA in Bensalem to reduce pain because they have spinal stenosis. Is that only a start to reduce pain, and what could be the next step?
Yeah, so the RFA refers to something called the radio frequency ablation. So that is, there are nerves that you can imagine that give us the sensation, and there are some nerves that actually even give us a sensation of pain. So if certain nerves are identified to something called the facet joint, the facet joint capsule, that are deemed to be completely sensory, but sensory and painful, those can be ablated. So the nerve is essentially burned so that it doesn't grow back, and the areas of pain can be numbed. So that's what an RFA is. Depending on the success of the RFA or the levels that the RFA needs to be performed, that can help determine the longevity and the lasting effect of that procedure. And then if that procedure does lose its effect, ultimately a surgery can be considered to stop the motion at that painful joint.
Okay, thank you. One question is, what is your opinion of the Minuteman procedure?
So it's kind of the Minuteman procedure is a newer procedure that allows fusion of the posterior parts of the spine to be performed, but instead of using the typical screw type technology that I showed on the X-ray to affix to the spine and create the limitation of motion between the motion segments. It's a different method to connect the two levels of the spine together. I would tell you that it does show some areas where it can be used as an adjunct for fusion, but I would say that I'm hard pressed to say that the Minuteman procedure can be used alone to create an adequate amount of stability to promote a fusion.
Okay. One question, what can you do after a rhizotomy was not effective for lower back pain?
So that is also in the sort of lines of the question before about the RFA, and it's a rhizotomy is essentially a different sort of form or method for that RFA. So the answer would be the same, unfortunately, is that probably consideration of the surgery to determine if stopping the motion of that painful motion segment would lead to pain relief.
Thank you. There's a ton of questions here, so just going through some.
Mhm.
Let's see. One person said, how long does a typical surgery last and recovery time? That could be pretty broad, though. Not sure what surgery they're referring to. Maybe obviously the
Yeah.
most invasive, but you want to touch on that?
Um, yeah, I mean that's a little difficult because there is a whole broad swath of procedures that aren't all the same in terms of the answers to that question. But I would say just sort of the ends of the spectrum. I mean, there's some surgeries where I would say really it's a 4 to 6 week recovery time to some that are 1 to 2 years long. So sorry for the wide ranging answer, but the types of surgeries that can be done can be a really broad range.
Thank you. Um, Someone asked if you can do a fusion with minimal invasion.
Yes, that is actually the most common type of treatment done through the minimally invasive approach. Now, again, the caveat being there are some conditions of the spine and how wide ranging the diseased areas can be that are being affected that don't lend itself to minimally invasive approaches, but to the ones that are, a fusion can be performed through that approach.
Yeah. How does age of patient affect the decision by a surgeon to proceed? For example, if a patient is in their mid 80s.
Yeah, it's a great question. The really the adage is probably true that age is just a number. So really, it's more about the overall functional status as well as presence of other medical conditions. So that really are conditions that typically do change with age, but it isn't always a hard and fast rule about if there's an age cutoff for being able to have surgery or not. But those are the other factors that I would say are more important than just the age itself. Also, too, one aspect of these procedures is that because they are typically less of an sort of insult to the body and the amount of either time needed or um, muscle that is spared or not, it's possible that some of these procedures can be performed on patients that would generally not do as well under a longer type procedure under general anesthesia. So it is possible that this does expand the age range where these surgeries can be considered.
Thank you. A couple people asked if any of these minimally invasive procedures can be done for patients either with osteoporosis and or scoliosis.
Yeah, so those are two conditions that do that can make this type of method to perform the surgeries more difficult to perform and sometimes make it altogether impossible to perform through these type of methods. And you have to generally um, respond with the more traditional open approaches. So yes, those are two conditions that make it difficult to address fully by these methods.
Okay. If someone has gotten epidurals, for a while and they've worked, but now they don't anymore, is the next step surgery typically?
So that's a good question, and it speaks to the kind of beginning of my talk where I was saying that yes, it is beneficial probably at that point to have a consultation with a surgeon, but what the results of that consultation could be are yes, this is a condition that lends itself well to a surgical treatment option, and you're a good candidate, or no, this is not a condition that can be treated with a surgical approach, or surgical results are so variable for this type of disorder that it would be hard pressed to recommend surgery. So the short answer to your question is likely consult with a surgeon at that point to determine the appropriateness of the surgical treatment option.
Thank you. Another question is that do injections damage the bone?
And that's a good question. There has been studies that have shown over a long period of time, and when I say long, we're talking in the order of years, perhaps 8 to 10 years, and multiple injections somewhere in the range of 25 to 50 to 100, where a lot of steroid can lead to weakening of the bone. But again, this was like a very, very large number of injections. So you would not see that at I would say, typical recommended dosage or number of injections.
Okay. One question or one comment and question, diagnosis with somebody has a diagnosis with lumbar radiculopathy with multiple bulges in the lower 5 vertebrae. Is the surgery geared for multiple sites?
That's another subtle question, because again, if there are multiple sites that need to be addressed, you do lose some of the effects of this more minimally invasive approach. So by keeping the area very targeted and very slim in terms of its profile, that will allow, I think, the maximal benefit from these type of procedures. However, once you start getting into the 3, 4, 5, 6 level range, predictably a more traditional open approach will likely be recommended in those kind of cases.
Thank you. Another question just came in. What is the recovery rate for using surgery after trying needles, I guess, injections? So after you've done multiple injections and then you may need surgery, is the recovery rate different than someone who just goes right to surgery?
Yeah, no, I think I get the question. I think, I think it is safe to, so the disease process generally itself is very, can be very slow going. So the fact that if there is either time taken to try other treatment options or time to do injections, you generally can achieve a lot of the same results whether you do the surgery sooner rather than later. So it generally is safer to try some of the other methods first before pursuing surgical treatment.
Okay. Somebody asked in some of the pictures, it looked like the x-rays showed post minimally invasive surgery screws. Does stabilization require hardware even with the minimally invasive procedures?
Yes, any time that you would want to stabilize a spine, which is typically what needs to be done to perform a fusion, will require instrumentations. There are very few rare exceptions where the instrumentation would not be used to perform the stabilization. But yes, generally when there is stabilization, it requires instrumentation, which are the screws.
Thank you. Does neuropathy continue to worsen if it is currently tolerable but varies?
I'm sorry if I maybe misunderstand exactly the question, but I would say the answer to the question of, does this continue to get worse if left alone? I would say it can continue to get worse, but it will continue at a very, very slow rate. So generally it won't rapidly progress. Now, there are instances where things can change rapidly, but in general, this is a slow going process.
Thank you. One question is, when do you do a form-anatomy versus a fusion procedure?
So that would be, again, dependent on individual specific imaging demonstrating where the nerve compression lies and how much the area of bone or tissue that needs to be removed to relieve the compression is going to affect the stability of the spine afterwards. So that's going to generally be the determination of a laminectomy or foraminotomy alone versus a laminectomy and a foraminotomy with a stabilization or a fusion.
Thank you. Someone who has osteoporosis, if they get an epidural injection, could that cause a negative influence on the osteoporosis?
Now, I think that's going back to the question about if there is an association between long-term steroid usage and weakening of the bone, and that can happen. But again, that's at a very, very high rate and a very long period of exposure of the bones to the steroid.
Thank you. Just seeing if we have any
Mm-hmm.
other specific questions we haven't really touched on here. No, a lot of them are pretty similar. Do you see any on here, Dr. Cha, that
Let me see.
yeah. Someone asked if there's any
Yeah.
literature, the literature question. I don't know if you see that one. If there's any literature that might
Yeah.
be
I
understood.
think I think I would we have a wealth of resources on our website that include some blogs that are written by some of our surgeons that describe some of these techniques in very digestible, understandable terms. So I would go there to see if there's something that would speak to your specific question.
Okay. All right. I think we answered a lot of the questions that came through. If there's any specific questions that you have or something more personal to your situation, again, like I mentioned, that an appointment may be a better option for you. But
Yeah,
I think you answered a lot of the questions, Dr. Cha, and thank you for the very informative presentation. Everyone who did join this evening does have my email, so please feel free to reach out to me directly if you do need an appointment or have any questions after we log off this evening. We also did record this, and it will be sent out possibly by the end of the week or early next week to everyone who registered. So you will be able to view this after as well. So thank you, everyone. Thanks, Dr. Cha. I really appreciate your
excellent.
time and everyone for joining us this evening.
Yeah, appreciate it. Okay,
Yeah.
take care, everyone.
Have a
Good
great
night.
night.